Thank you all for joining us today. My name is Robert Malad. I will be your host for this session. This session today is on advanced treatment planning with Dr. Resnik. I am Robert Malad. I'm with 3D Diagnostics. Just a quick overview about 3D Diagnostics. We're a computer-guided surgery company who's processed over 100,000 cases in the last 15 years. We're based out of Boston, Mass. And we provide turnkey solutions for your implant cases. Our customer support team is dedicated to serving both East and West Coast times. So we operate from 8 a.m. Eastern to 8 p.m. Eastern. Some of our services and products that we have available to our dentists are our implant planning services, which is done by our in-house dentists, where you will log on to a GoToMeeting session and plan your case with them. We also provide surgical guides for all the major implant companies, whether it's tooth-borne, bone-supported, or mucosa-supported surgical guides. We also have bone reduction guides, and more recently, we've added our guided full mouth restoration solution. So that's also known as the stackable guide. We also offer comprehensive radiology reports and implant planning software solutions. We also sell in-house 3D printers where you can print your surgical guides in your office. And then, of course, due to COVID, we do offer services in regards to your needs for PPE, like the KN95 masks or N95 masks and face shields. If you have any questions, please feel free to ask them in the chat. We have a designated team out here who's going to be answering your questions, and we look forward to this session. So give us a few minutes and we'll get started with Dr. Resnik.
Okay, thank you, Robert, and welcome to our third webinar with 3DDX and the Mish Implant Institute. As Robert was just saying, he is the 3DDX representative to the Mish Institute, and the genesis of this treatment planning webinar is that we do this treatment planning on Saturday during our Mish Institute sessions, and it's been a big hit. It's one of the most popular parts of our curriculum. So we decided to do it in webinar form, and we've done two so far. Got some great feedback, and a lot of people really liked it. We made it interactive, and I'll explain that in a second, but a lot of this is kind of what we do with Robert and I on Saturday. So with that being said, we will let me explain exactly how we're going to do this. The first thing I'm going to do is go over a patient. We're going to do actually two cases tonight, two patients. I will first go over the medical history, then I will go over the medications, and then the dental history. And then we'll talk about the doctor's concern. What the doctor's concern is, these are cases that some of our doctors have sent to us that basically need help in treatment planning. And because of that, we've asked them, with their permission, to share this with you. So you can see how we start at the actual medical and dental history, go through the patient's concerns, and then we talk about some of the doctor's concerns on what they're worried about or what they're looking to do in the case. So we'll end up with each case with CBCT images describing the bone volume, bone density, prosthesis, etc. And then we'll come up with a treatment plan for the doctor. In between all this, after each section, I will actually ask you a question. And the questions will be in this type of form, and you will see a quick poll. And all that you do is you go on your computer, and we're going to give you about 10 seconds after I read the question and the answers, and you'll select an answer. Right after that, Robert will put the polling numbers up, and you'll see what the rest of the people on the webinar selected as the correct answer, and we'll actually get a percent breakdown. So it's worked very well. We've got a lot of feedback, and with that being said, if you have any questions concerning any of these cases, you can actually email a case or email the question, and during the after the first case and then after the second case, I will answer questions from the webinar attendees. With that being said, as Robert said, I'm Dr. Resnik. I'm the director of the MISH Institute. I've been there since the very beginning, over 30 years, with Carl Misch in the genesis of the MISH Institute. We have been doing these treatment plan sessions at the Institute for almost 20 years. Dr. Robert Millard, who you just met, he is a 3DX sales director. He's actually a physician who likes to spend time with us. So he comes to all the MISH sessions, and he's a great asset. He's a great, people really love him, and he really knows what he's doing, and he knows the software very well. So again, he will kind of quarterback this with all the questions and the answers. We had Khaled Assad. He is the CEO of 3DDX. He will be on. So if you have any questions for him, or Alex Zephron, he is the marketing manager for 3DDX. They will also be on. So you can email them questions. They will get right back to you, or they can make arrangements to speak via phone. We also have Heidi Cartagena, who is the executive director of the MISH Institute. Heidi's been with MISH Institute from the onset also, so she's been there for 30 years. She will ask or answer any questions you might have about any of our upcoming courses. And then we have our faculty director, Dr. John Connis, who will be helping with the questions, and he will commentate some of the questions at the end of each case. So if we look at the first case, and the first case that I've selected, this is a doctor who sent it to us, who is going through our course, and it's missing number 13, number 14, and number 15. The medical history includes it's a 60-year-old female. She has a history of osteoporosis, and there's no known drug allergies. She's only on one medication, and she's taking Reclast, which is a form of Zometa. So this patient's missing 13 through 15. The medical history is osteoporosis, and she's taking Reclast. Her dental history is she has been missing these teeth for some time. She's presently wearing an ill-fitting maxillary RPD, and she has opposing fully dentate, full coverage restoration crowns. So the question on this case is going to be how to restore number 13, 14, and 15. So when we look at this, I have a first couple questions. Question number one, and I would like all the attendees to answer this. With respect to Reclast, what type of medication is this? Is it a bisphosphonate, A? B, is it a biologic? C, is it a human parathyroid hormone? D, is it an osteoblast antagonist? Or E, is it a monoclonal antibody? So please answer A, B, C, D, or E. And then Robert will do a quick poll, and we'll see how everyone did on our first question of the night. Okay, excellent. We got almost 90% picked bisphosphonate, which it is. So if we look at the answer here, Reclast is a bisphosphonate. It's an IV bisphosphonate. So if you're not familiar with this, you're probably familiar with the oral bisphosphonates, which are like Fosmex. Beneva. But Reclast is in the past, which is Zometa, was used for multiple myeloma patients, also metastatic cancer patients. However, now they are using it for osteoporosis patients. So why is this a concern? Well, number one, this is an IV bisphosphonate. And as you know, IV bisphosphonates have a high incidence of osteonecrosis and cause a lot of problems. And we'll talk about that in a minute. Why is it not a biologic? There are a lot of new biologic medications, which are like Humira, which are very detrimental to the healing process. And we talked about that, I believe, at the webinar 1. Human parathyroid hormone, that would be the most common one is Forteo. Forteo is also used for osteoporosis. So some of you might have heard this drug before. It's actually an injection daily. But the good thing about Forteo is there's no reaction with anything you're going to do in the oral cavity. So there's no history or no problems with getting osteonecrosis or any immunosuppression in that way. D, why osteoblast antagonist would not be the correct answer is most of the bisphosphonates Reclast are osteoclast antagonists. So they interfere with the bone removing cells, the osteoclast. And then the monoclonal antibodies, which are used for osteoporosis, most common one being Prolia, denosumab. That is it's becoming more popular, the Prolia, and that does have advantages over Reclast in that it does not cause the immunosuppression or the osteonecrosis as much. It has a short half-life of about 26 days. So usually with Prolia patients, they get a subcutaneous injection twice a year. So it's every 6 months. Those are usually not problems. So Reclast is something that you should be concerned about when you see that. So my next question is Reclast an absolute or a relative contraindication to placing dental implants? So basically, is Reclast an absolute, meaning you never do it, or is it a relative, which means you can do it under certain precautions? So please select A or B. Okay, well, this was a little bit of a trick question. So if you look at, most people did pick relative. And for many years, we have said that it is a relative contraindication. However, as you can see, I have the answer as absolute. The reason is, unless you have experience treating osteonecrosis and some of the devastating effects of that, the FDA has put warning labels on Reclast, and this is their warning label. So if you look at what I have highlighted down below, avoid having any type of dental surgery while being treated with Reclast. So this is a very stern warning not to do surgery on these patients. Now, I would make an exception to that if you are, again, if you have the ability to treat these type of problems that can arise, then certainly it would be a relative. For most people, right now, medical legal issues, you have to really think twice about doing these patients. So the good news is these patients aren't on Reclast for many years. So usually they're on 3 years or less. So even if they are on, there is a little bit of a waiting period. As for a drug holiday, that usually doesn't exist for it because it is a 1-year infusion. So the advantage of this, a lot of rheumatologists put their patients on this because they don't have to take it an oral bisphosphonate. The IV, you go in once a year and you get an infusion, and it's very easy. However, there are some detrimental effects of it. Zometa, which is Reclast, is very, very toxic compared to and causes a lot more problems than the Beniva or the Fosmex oral forms of bisphosphonates. With that being said, let's go to our next part of this. So we're going to get into the treatment planning. So again, this patient is missing 13, 14, 15. Their chief complaint is they can't wear their upper partial and they want fixed teeth, meaning they want teeth that do not come in and out. The doctor who reached out to us, his concern is how many implants do I need to replace 13, 14, 15? And is sinus bone grafting indicated? So we're going to answer both of those questions for this doctor. So if we first look at treatment planning, I went over this in session 1 and in session 2. You will see that you always want to give all your patients all of the feasible treatment plans, one being no treatment. So it's always better to give it in writing because then there's no question about it. And if you use my form here, which I talked about last time, it's in the textbook, and it goes through all the advantages and disadvantages of each one of these treatments. But let me just go through some of these very quick. You always want to tell the patient they don't have to do anything, but what are the consequences? Decreased mastication, bone loss, maintain prosthesis. Why do we want to tell the patient they don't have to have anything done? Because if they don't have it done, we don't want them coming back years later with significant bone loss, and then they ask you why you never told them about this. So you can use this as a informational avenue to explain if they don't have treatment, what the consequences are. Treatment 2 would be a partial denture, decreased mastication, bone loss, loss of abutment teeth. Now, why do you want to give the patient the option of a partial? Well, again, talk about the disadvantages of partial. And I have one study. If you look at the textbook, I have multiple studies. But just in this study, after 5 years, you have 28% chance of failure. After 12 years, about 44% of the abutment teeth will be lost. So, Mrs. Smith, yes, we can make you a partial, but this is the consequences of wearing a partial. And then that leads you into the implant. And that gives us our fixed prosthesis. So obviously everything leads into the implant, which in this case, the patient's chief concern was they wanted fixed teeth and nothing removable. So in summary, give all your patients all the viable treatment options. So let's look at the CBCT evaluation. So if we look on the right side of your screen here, what we have done is we put some virtual teeth in. So I have number 13, 14, and 15. You can see a little space between where the clinical crown is and where the crest of the ridge is. So we know they have lost some vertical height. We know from the lower dentition,
there you go. I'm in.
They have a second molar occlusion. So they have a second molar occlusion. With that being said, if we look at a sagittal view, so you can see where the outline of the teeth are. And if we look in the number 13 position, you see a little bit of a crestal defect. Number 12 is a straight root, which is good. Number 14, you can see the sinus actually pneumatizes in that area. So you have very little bone in 14, but then back in 15, you have a lot more bone. So if we look at each individual cross section, Number 13, on the right, you can see the actual cross section, and the bone is highlighted there in the white. Number 14, you can see it goes down to just a few millimeters. And then number 15, you can see where we get a lot more bone there. So there is a wide variation in the amount of bone. So let's next go to some basic CBCT anatomy questions. I always like to throw these in just so you can look at every aspect of this case. Hey, Robert, could you take that back off so they can see this? Could you take that question off? Okay, good. So is there pathology present in the maxillary sinus? So look at this cross-sectional image, and is there, yes or no, pathology within the maxillary sinus? So A is yes, B is no. Okay, and our results are yes. So about 74% of you answered correct. And let me explain why that is correct. So if you look at, I don't know if you can see that cursor, but my cursor is right on this pathology. So if you're not used to looking into the maxillary sinus and see what is pathology and what is not, basically the sinus cavity should be radiolucent. It should be completely black. It should be air. If it is not air, then anything in the sinus is either an anatomic variant or it is pathology. So you can see by my yellow arrows, this little dome-shaped gray area within the sinus that's less dense than bone, which is what we would term pathology. Not significant pathology, but it still would be termed pathology. So in question number 4 is, what is this pathology? So I have on this upper, which is the cross-sectional image, 2 arrows that point to that grayish area, and then the sagittal area, the 1 arrow below it. So is this pathology A, mild mucosal thickening, B, pseudocyst or a mucus retention cyst, C, is it a polyp, D, is it an anthrolith, or E, is it fungal growth? So Robert, put the question up. Please pick A, B, C, D, or E. And our answer is A. Very good. Mucosal thickening. So let's see why that is mucosal thickening and the other answers are not correct. So if we look at what is this pathology, right here, if you can see my cursor on this upper 2 arrows, it is mild mucosal thickening. Pseudocyst, a lot of you did pick pseudocyst, which if you would look at the sagittal image, you would most likely call that a pseudocyst. But after looking at that cross-sectional top image, you can see where the membrane, it's actually just membrane thickening because it is not one dome. Secondly, a pseudocyst, if you don't recall, is the reason it's called a pseudocyst is it's not a true cyst. It doesn't have an epithelial lining. Because of that, what it has is one dome-shaped, basically designed to it that is only on the floor. It's usually associated with some odontogenic issue, and it is always on the floor because this is kind of on the lateral wall also. That would be that would give credence more to the mild mucosal thickening. Polyp, which is usually in allergic rhinosinusitis patients, is almost always starts up by the ostium, spreads to the walls, and then the last area is usually on the floor. An antrilith is any calcified mass in the maxillary sinus. So if there is a burr, if there is a tooth broken off, if there is an implant up in the sinus, it will calcify, and that is then called an antrilith or a calcified mass. E would be fungal growth. Fungal growth is usually depicted by a completely radiopaque sinus with more hyperdense areas within the sinus, which is the actual fungal growth. So it wouldn't look like this. Again, it would be a completely opacified sinus. So A would be the answer. Number 5, is this cross-sectional image, within this cross-sectional image, is the maxillary ostium patent? Yes or no? So if you look at this image, look at where the maxillary ostium is. Robert, take that off one, just give us a couple more seconds here. Okay, look at that, very good. And see, is the maxillary ostium patent in this specific cross-sectional image? A would be yes, B would be no. Go ahead, Robert. There we go. Okay, and our polling results say yes. B is the correct answer. It is not patent in this particular cross-sectional image. However, that was a trick question because as you remember, we always, when we're looking at the patency, again, the patency is the opening of the ostium. So if the ostium is open, that means that the maxillary sinus can drain. That would mean it is patent. If it is closed off, which it is in this cross-sectional image, then the sinus cannot drain. However, you always want to look at continuous slices. So if you look at my arrow here on this coronal image, it is not patent. On this image, it is not patent. On this image, it is not patent. On this image, it is not patent. So every time I click, it's about 1 millimeter. On this, it is. So the reason I put that question in is to, again, have you, don't look or remember what you learned back in dental school radiology where you look at one image and that gives you your diagnosis. When we're looking at maxillary sinuses, we have to look at multiple images because there are different layers of the anatomy that we have to look at. And what we're looking for is this ostium to be patent. As you know, that maxillary sinus is one of the 4 paranasal sinuses. If the ostium is not patent, you certainly do not want to violate the maxillary sinus in any way. What do I mean by that? You don't want to stick an implant 1 millimeter into the sinus. You don't want to do a bone graft. You have to make sure that your ostium is patent prior to doing any bone grafting or implant procedures. And that is how you see it. So if we go back again, we start here, and if you click 1 millimeter in either direction, it'll get you to the point where you will actually see an opening or where you won't see an opening, and you want to verify that that is draining. Okay? Question number 6. In this coronal image, what is the significant bony anatomic variant? Is it a concha bullosa? Is it a paradoxical turbinate? Is it a deviated septum? Is it an atopic lacrimal gland? Or is it a deflected uncinate process? So look at this coronal image, and there's one significant bony anatomic variant that could be very, could cause a lot of complications to placing an implant or doing a bone graft in the posterior maxilla. So please pick A, B, C, D, or E. Okay, let's see what we have, Robert. Okay, we have 68% pick the correct answer as deviated septum. So you can see here, I have the yellow arrows depicting the deviated septum to the left. Now, why is that a concern? If you look on this image, you can see the right ostium is completely patent, but the left ostium isn't. When you have a deviated septum, what that does is that presses on the middle turbinate. That middle turbinate then presses up against what is called the uncinate process, which is the opening of the maxillary ostium from the nasopharynx. So when you have a deviated septum, what it actually does is it puts pressure on that middle turbinate to close off the ostium. So if this was your patient and you were doing a right-sided implant or bone graft, the anatomic variant wouldn't be a problem. However, if you were doing a left, it possibly could be a problem. And depending on how severe it would be, would depend if it is a contraindication to implant surgery or bone grafting. And usually that would be resolved with a ENT consultation. So if we look at number 7, if we look at this coronal image, you will see 2 red arrows or 2 red circles. Is this the sphenoid sinus, ethmoid sinus, maxillary sinus, frontal sinus, or is it the anterior cranial base? So please pick A, B, C, D, or E on what is depicted in that bilateral red circles. And our answer is very good, B. So most of you did get this. So the ethmoid sinus is the correct answer. Now, why is this important for what we do? Well, if you place an implant or do a bone graft into the maxillary sinus and cause an infection in any way, the ethmoid sinus, the anterior ethmoid sinus, communicates with the maxillary sinus in an area called the osteomeatal complex. If you cause an infection in the maxillary sinus, that can cause an infection in the ethmoid sinus, which is medial to the orbit. So you can see this can get into a real bad situation where you end up with an ethmoid sinusitis secondary to an implant or a bone graft. So that's why it's important to determine and make sure that that maxillary ostium is patent. So the answer is B. Our next question, this is an axial scan. So this is taking a slice of the patient's anatomy top to bottom. So this would be a slice basically making a top and a bottom image, and this is what is in between. Is the area depicted by the red circle sphenoid sinus, ethmoid sinus, maxillary sinus, frontal sinus, or anterior cranial base? So please pick A, B, C, D, or E. And our results are, Robert. Very good. Most of you picked sphenoid sinus. So this is called the sphenoid sinus. The sphenoid sinus is a bilateral, one of the 4 bilateral paranasal sinuses. This is actually under the cranial base. This is a common area to have a sinusitis where it will exhibit headaches. So patients with chronic headaches can sometimes have a chronic sinusitis in this area. And most CBCT mid-field of view scanners will not show this. To see the sphenoid sinus, you really need a full field of view, so a large field of view to see it. But again, this is one of the paranasal sinuses that need to be evaluated if you do take that large of a scan. And that is why, if you haven't taken any of our courses or read the book, you will see that we recommend a midfield of view scanner, not a full field, because a lot of this you really don't need for your diagnosis for implants and or bone grafting. So with that being said, you did very well on those anatomy questions. One of the big questions I get a lot from doctors is the maxillary sinus. And so I wanted to highlight one of our former residents, Dr. John Suzuki. This is Melody Chow, and she was one of Dr. Suzuki's residents at Temple University Perio program. I know everyone knows Dr. Suzuki's world famous periodontist, and one of our brightest and best lecturers in the field of implantology. But his resident, Dr. Chow here, actually did 4 studies. And why I think these are so great, and you should try to read these studies, because what Melody did is she looked at patients coming into the perio program at Temple who needed sinus bone graft surgery, and found and looked at the prevalence of, number one, pathologies. What she found was 37% of these patients asymptomatically had pathology in their sinus. So that pathology that I was talking about is very important. That's why I have a whole chapter dedicated in the new contemporary implant dentistry, and also a chapter in the complications book just to a differential diagnosis of that. She also did one on sinus septum. About 44% of our patients have septum. Now, why is this important? Well, a lot of people like to do the crestal approach sinus grafts now. Well, if you have septum there, that complicates it, increases the risk of perforation and morbidity if you have a septum. So you have to know where those septums are. And as you can see from that second study, almost 50% of the patients have this. Odontogenic related pathologies, about 36%. If you look at the ENT literature, it's becoming very significant that chronic sinusitis patients who come in and say, I have had sinusitis all my life, a lot of these patients have teeth that are causing the problems. So asymptomatic teeth that are actually, instead of the tooth causing the problem, it is the problem, but relating the area, the sinus is actually showing where the pathology is, just because close to 42% of maxillary molar roots are into the sinus proper. So that's something to think about. And then 84% have interosseous anastomosis. What is that? That's a blood vessel anastomosis in the lateral wall of the posterior superior artery and the infraorbital artery. And this can result in a bleeding episode during a surgical procedure. So again, you should determine if that is present, and you can see from Melody's study, 84%. So what's the conclusion on all these studies? Whenever you go into the maxillary sinus, whether it is bumping the implant in 0.5 millimeter or placing a lateral wall sinus graft, you should definitely have a CBCT to make sure there is none of these asymptomatic pathologies, anatomic variants, or any of these issues that can really cause a problem. So let's go into some treatment planning questions. So this is number 13, this is number 14, and this is number 15, as I showed you before. If we look at the amount of bone between the alveolar crest and the sinus floor, number 13 has 3 millimeters, 14 has 2 millimeters, and 15 has 5 millimeters. So question 9, how many implants should be placed in this case to replace those 3 teeth? 1, 2, 3, 4, or there's not enough information given. So Robert, put up the question and please select A, B, C, D, or E. And our polling answer is E. E is the correct answer, not enough information. So let me go over why that would be the correct answer. If we, actually, I'll do it with this question. What factor or factors should you evaluate to determine the number of implants? The opposing occlusion, parafunction, bone density, available bone, or E, all the above are factors which should be considered. And Robert, go ahead, put that, there you go. Okay. So what do we have? 99%, very good, said that we should look at all those factors. So let's go through those. Why did that previous question, was there not enough information? I really didn't tell you with the opposing occlusion, even though at the very beginning I did say that, but in this particular question, I didn't add that. Secondly, is there a history of parafunction? Well, number one, if you have opposing occlusion that is natural teeth, we exhibit a greater biting force. If the patient has a history of parafunction, we know that biting force is increased significantly. So with those two, A and B, not knowing those true factors there, that really, we wouldn't know whether to do 2 or 3 implants, because if the patient does have fixed teeth or natural teeth, has history of parafunction, we want more surface area. More surface area is the easiest way to do that is with more implants. The bone density, I didn't tell you what the bone density is. If it was D4 bone, which is the worst bone density, we need more implants. If it's the D2 bone, which is rather uncommon in the posterior maxilla, then we would need less bone or less implants. The available bone, how much, where is the level of the crest? Is there a horizontal defect or vertical defect, and is there a horizontal defect? So you need to look at all these factors and take all those factors into consideration to determine the number of implants. So that leads us to the last question. With the amount available, so let's go back to this specific case. With the available bone described below, what would be the ideal treatment plan for placing 3 implants? So we've determined that there's parafunction, poor bone density, very little bone. We're going to place 3 implants. How are we going to do it? Number one, are A, is implants contraindicated? B, are we going to place 3 implants into this existing bone with no bone graft? C, are we going to do a crestal sinus graft and then place 3 implants at the same time? D, are we going to do a lateral wall sinus graft and then wait till complete healing, then place the 3 implants into the healed bone? Or E, that should be E, none of the above are viable options. So please pick A, B, C, D, or E. And our answer is, it is D. Very good. 82% of you got that right. And why is that? Whenever you're looking at whether to place the implants at the same time or do a delayed approach, and this is almost conclusive in the literature, 5 millimeters of host bone is needed. Now, why is 5 millimeters needed or more? Because when you place the implant, the primary stability of that implant is achieved by the crestal bone. Because there is very little crestal bone in the posterior maxilla, if you don't have a lot of crestal bone, such as in number 14 area, you would put an implant in and it would be basically floating in space because there won't be enough bone to hold it in or enough strong bone. Remember, there are two types of stability. The primary stability is the stability when you place the implant at that time. However, as the bone, the osseointegration process and the bone remodeling process advances, it goes into what we call secondary stability. So at approximately 6 weeks, that bone is weaker than the day that you put it in. So if you put an implant in with only 2 millimeters of bone or less, there's a good chance that implant could get avulsed up into the sinus. And that's why you're seeing a lot of articles coming out on migration of implants because there is not enough fixation. So the rule of thumb, always look at 5 millimeters of bone. So if you see that center CT scan that I'm showing, you want to graft it first. If you have less than 5 millimeters, let it form into bone, and then go back and you place the implants in the ideal position into healed, good load-bearing bone. And that is what we call an SA3 or an SA4. We actually have 4 different approaches, and this goes back to Dr. Carl Misch in the late 1980s, devised the SA1, SA2, SA3, SA4 categories. Okay, so our first case is done. Do we have any questions on that first case? We'll answer a couple right now before we go to the second case. Robert, do we have anyone?
Nope.
We have no questions. Okay, we'll do those at the end then. Okay, let's go to the second case. Case number 2, missing number 18, 19, and 20. We have a 60-year-old male, medical history. They have a titanium allergy. So I threw a little curveball on this one for you. Medications, 81 milligram aspirin. So let's look at some questions concerning these medical history. What dental implant complications can arise if the patient has a true titanium allergy? A would be localized tissue inflammation. B would be implant failure. C would be pain. D would be skin dermatitis. E would be all the above are possible complications. So a patient has a true titanium allergy. What would be a symptom or symptoms or complications that can arise from that? Please pick A, B, C, D, or E. And our answer is almost 96%. Very good, E. So if you look at what can happen here, let me go back. All of the above can happen with a true titanium allergy. So you can get localized tissue inflammation, which is probably the most common. Implant failure, it eventually will lead to implant failure. It is usually very painful. You can get skin dermatitis or issues in the soft surrounding tissues. So the answer to that question is actually E. Our next question, in the literature, what is the approximate prevalence of titanium allergy in the US population? And that is due to a study that was done evaluating this. Is it 0.01%, 0.6%, 5.2%, 10.7%, or 15.8%? Robert, the question or the question and answers. So please select A, B, C, D, or E. Okay, and oh, very good. B is the correct answer. So we did pretty good on that one. So if you look at titanium allergy, let's talk about that for a couple minutes. First of all, I call it the old days. When I first started out, Carl Misch and I, we would always tell patients, one of the advantages of a titanium implant was there's no true allergy to titanium. However, back in the 1980s and 90s, we use commercially pure titanium. Because the commercially pure titanium is soft and it breaks, it fractures, the manufacturers had to come up with a better metal. So they came up with an alloy of titanium, and you might have heard of 6-4 titanium. So 6-4 titanium is grade 5 titanium, which is basically a titanium alloy. And because of that, there is now incidences of titanium allergy, and we hear a lot more. Now, I get this call a lot from some of our doctors that they have a failed implant, they think it's an allergy, or the patient's having pain, it's an allergy. The allergies that I have seen, the true allergies, have had soft tissue ramifications, so you do get bleeding and redness and a lot of pain. But if you look at the orthopedic literature or the cardiovascular literature, those colleagues of ours have a lot more problems. Can you imagine getting a knee, hip, shoulder put in, and because those are titanium alloy prostheses, getting an allergy or having a reaction to it and it being a real problem. So cardiovascular surgical clips, that is a issue. After you have surgery, you have all the surgical clips in and the patient has an allergy. So going back in those situations is very detrimental. In our situations, placing implants, in this case that I'm showing you right here, after those 2 implants were taken out, the skin and the intraoral tissue problems resolved almost immediately. So there is titanium allergy. It is here. And as people become more sensitized to titanium, they are getting sensitized from watches, even glass frames. There is titanium particles in that, and that's a whole nother topic, which you can come back to at another time, but the titanium particles that float around in the system are causing immunosuppression in some patients, and that's going to be a controversy moving forward. With that being said, let's move on. What is the most accurate test to determine if your patient is truly allergic to titanium? And this is a difficult question. I'll tell you why I put this in afterwards. A is a patch test. B is a blood test, specifically the Melissa test. C is to take a CBCT. D is to tape a titanium abutment to the patient's forearm. And E, there is no true test for titanium allergy. So Robert, We have A, B, C, D, or E. Please pick an answer. Very good. Wow, Robert, that's impressive. Okay, so why did I put this in? Well, we kind of screwed this up years ago. Carl Misch and I, we would do this all the time. Patients would come in, I have an allergy. We'd get a titanium abutment, pure titanium abutment, get their forearm, just scratch the skin lightly, put a Band-Aid over it, and attach the abutment to the skin and have them come back in a couple days. Well, we found out that really doesn't work. True patch tests where they take titanium and apply it to areas of the body have been shown to not be accurate. It gives a lot of false results. The actual blood test that you should, or the test that the allergist or the dermatologist usually will call for is the Melissa test. And the Melissa test is for titanium hypersensitivity. Now what orthopedic surgeons are doing is before you have a prosthesis put in your body, they're actually having the Melissa test done on a lot of patients. So some orthopods and neurosurgeons for spinal surgery before they plate people are having these tests just to try to counteract the titanium hypersensitivity. But that is going to be a hot topic for the future. And again, we can talk about that in a future webinar. You determine the patient to have a true allergy to titanium. So you send them to the allergist or their physician, come back, they truly do have a titanium alloy allergy. How would you alter your treatment plan? Implants are contraindicated. Administer prednisone when placing the implant. Administer an antihistamine when placing the implant. Place a zirconia implant or place a coated titanium implant. So Robert, go ahead, please pick A, B, C, D, or E. And our results are very good. 82% said place a zirconian implant. So let's talk about zirconia implants. Zirconia implants have been around for a while. They've gone through many, many phases. Some of the problems with zirconia implants, if you look at the latest studies, and I don't have time to go through all this tonight, so I'll give you a Cliff Note version of this. The latest studies actually show really no difference in failure rate between a zirconia implant and a titanium implant. The problem that I see with zirconia implants and a lot of the older ones was they would fracture. So you have a weak point between the abutment and the actual implant body. That's why some of the zirconia implant out there are one piece. But the problem with one piece zirconia implants are your implant placement has to be perfect. And then if you alter it by adjusting the abutment, which is attached to the implant, then that weakens it. And it's an area for biofilm to fill in, and it is problematic. Secondly, you do have issues when placing these implants. We're used to putting titanium implants where we're ratcheting them in with very good, strong insertion torque. With titanium implants, you can't use a high insertion torque. Each zirconia implant is different, but most of them have a very low insertion torque. So you have to end up over prepping the osteotomy site, because if you try to get it in with a high insertion torque, what will happen is you'll actually fracture the implant. And then zirconia implants have had problems after they're in the mouth and they're put under force. They can fracture, like that one X-ray to the far right. However, they are here to stay. They are going to be part of our future. Just the R&D, and they are making a number of advances on that. The best one out there, Glidewell just launched one, and it's a two-piece, and it has the best attachment system I've seen for the abutment. So question number 5, according to the latest literature, this patient's on an 81 milligram aspirin. How would you alter your treatment because the patient is on an 81 milligram aspirin? You would discontinue the aspirin for 1 day, 3 days, 1 week, 2 weeks, or no discontinuation of the aspirin. Now, this is according to the latest literature, and I define the latest literature as the literature in the last 10 to 15 years. So what should you do if the patient is on 81 milligram of aspirin, which a lot of patients are? And Robert, our results are E. I'm looking for the red. Okay, no discontinuation. 75% did get that correct, and that is the correct answer. Now, why is that the correct answer? Number one, never ever alter a medication that the physician puts the patient on. Always let the physician alter that medication. You don't know why that patient's on this medication. With aspirin, a lot of patients that have stents will be on a antiplatelet like Plavix, and they'll be on what is called dual therapy, which is aspirin. So they'll be on Plavix and aspirin. And they can have they can throw a emboli very easily if they're taken off the aspirin. So you never want to take off any patient that the medication was put on by their physician. Secondly, what the studies have shown, almost every study in the last 15 years has shown that that makes no difference in altering that aspirin. So usually we were taking them off in the old days, 7 to 10 days. But all the studies show that actual bleeding does not affect the implant surgery as much as it puts this patient at risk. So the bottom line is you have more of a chance of this patient have a cardiovascular issue than having a bleeding issue during the surgery. So all the studies say no alteration of 81 milligram aspirin. Now, if they're on a full aspirin, 325, that's a whole different story. That patient needs to, need a medical consult, and the physician usually has to make that call because those patients will definitely bleed. But it's not that common to see a patient on a 325. So let's go into the case. I know everyone's tired. They've been working all day. This patient's missing 18, 19, and 20, 60-year-old male. Chief complaint is they're missing teeth, and it's hard to chew their food without these teeth. So we're going to look at this left side. The doctor's concern is, which is a concern, is there enough bone to place the implant? No. So if we look at the 3D image, so this is a lateral view. You can see where the mental framing is. You can see where the natural teeth is. You can see where the vertical height of bone is. If we look at a occlusal view, you can see where there is rather significant horizontal bone loss. So you can see this concavity, which is rather significant of the amount of bone loss. So I have it highlighted here. A quick way to evaluate this is to look at the buccal and the lingual contours of the bone, and you can evaluate how much is lost by just looking at those buccal and lingual contours right around the adjacent teeth. So if you extrapolate a line like I did, and I filled it in with red, you can see this patient has lost a lot of bone. Now, why is this significant? Because remember, when you have a tooth taken out, you lose the bone from buccal to lingual. So the whole ridge shifts towards the lingual. However, when in the posterior mandible, you have the sublingual fossa. So you have a lingual undercut. So it actually, not only does it cause problems with the amount of bone, host bone to place the implant into, but it gives you an angulation issue to avoid perforating the inferior border of the mandible. So if we look at studies, the lingual undercuts greater than 2 millimeters occurs in 80% of patients. Other studies, 20% of our patients, this sublingual fossa area will have a direct influence on implant placement, either by the implant size, position, or angulation. So the bottom line is this is an issue. You always want to look at the angulation and the amount of bone that is there. So what are our treatment options? No treatment. They can wear their same prosthesis, decreased mastication, bone loss, and I talked about wearing an old prosthesis and the abutment failures. You can make them a new partial denture, but you have those same problems that I talked about in case 1. Or you can make them a fixed prosthesis. In this case, you can make them fixed crowns with implants, whether it's depending on how many teeth you're replacing, and that's what we're going to talk about right now. So we actually, in the software, the co-diagnostic software, we have missing 18, 19, and 20, and we've replaced those with virtual teeth. So right off the bat, if you look at this view, my concern looking at it right now is that we have a space between the clinical crown and the crest of the bone. And because of that, we now have a vertical cantilever issue because now we have a crown height issue or a crown height space issue, meaning where the implant is going to be compared to where the crown is, the crown to implant ratio is going to be compromised because of that. So if we look at number 18, this is a cross-sectional view. Actually doesn't look bad. The bone, there must have been a prior extraction site because you can see the bone density is not that great at the crestal area. Number 19 is rather compromised. So you can see the outline of the crown on top. You can see the thin bone down below. And then 20, which is right over the mental foramen, it looks like it is sufficient bone. We have adequate width and height, and there is not an angulation problem. Now, this is a good image. If you can see that purplish pink outline, that is actually the mental foramen. But a little anatomy class here. The mental foramen is the opening of where the mental nerve comes out into the soft tissue. Below or to the right of where that foramen is, that is called the mental canal. And the mental canal almost always comes from an inferior view. So or position. So you can see how it comes up. Why I state this is a lot of doctors will try to go lingual to the mental foramen. And what will happen is you will hit that mental canal if that happens. So be very, very careful of this. Secondly, immediate implants. If you place an immediate implant, this is an area of high incidence of neurosensory impairments. So be very, very careful. The studies show about 1/3 of the patients, the mental foramen is actually superior to the apex of the first or the second bicuspid. So be very careful with that. So what you want to do is evaluate the available bone. Here I have number 18, 19, and 20. You can see number 19 is certainly a defect. So that takes us back to how many implants do we need in this case? Well, let's go through the options. What are our options? We could do 3 implants. So what are the indications for 3 implants? Putting an implant in 18, 19, and 20. Usually we try to get minimum 5 millimeter diameter implant in a molar and at least a 4 millimeter implant in the bicuspid area. So what are the indications? Well, to do 3 implants, we should have 3 opposing second molar. So you should have an opposing second molar. Excessive forces. So this patient has parafunctional forces. This patient has poor bone density or compromised available bone. So those are all factors that would indicate doing 3 implants in the 18, 19, 20 position. When would we do 2 implants? Only in the 18 and 20 position. Well, number 1, we have an opposing second molar. However, we have normal biting forces. So we don't have a 350-pound middle linebacker here exhibiting 1,000 pounds per square inch in the first molar area. We have favorable bone density and favorable available bone. So 2 implants would be indicated when we have favorable force factors and we have an opposing second molar. When would we only do 2 implants, 1 in 19 and 1 in 20? Well, there's no opposing second molar. So if there's no opposing second molar or no plan to do an opposing second molar, there's no reason to put a second molar implant in, because the second molar implants are usually a lot more difficult and there's a lot more morbidity to that implant. So that's the third option. The fourth option would be 2 implants, 1 in 19, 1 in 20, and then put a ponic. When would we ever do that? Well, we need very favorable forces and we need an opposing second molar. When do I usually recommend this? Patient has an opposing denture. We know that a denture will, most people exert a force in the molar area of less than 50 pounds per square inch. And that would put very little force on that ponic area. However, if we have natural teeth, we know that that goes up to 250 pounds per square inch. If you have a crown on that natural tooth, it increases that significantly. If it's a opposing implant, that goes up to 500 pounds per square inch. And then if you put parafunction in, it can go up to 1,000 pounds per square inch. So certainly you want to cantilever that, because then with that ponic, that is a shear force. And as we know, bone is weakest in shear. And then when would you ever do this? 18, 19 implants and cantilever the ponic anteriorly. Well, basically the only time you would do this is if you had favorable force factors and the number 19 area is a poor surgical site. So there's a huge defect that would be difficult to bone graft, or infection in that site, something like that. But you can see one case, you have 5 different treatment plans. So you always want to get away from treatment planning to what you're comfortable with. Okay, I only like to put 2 implants in, or the patient can only afford 2 implants, so I'm only going to do 2 implants. You look at all the factors, and that's how you stay out of trouble and you prevent complications and issues post-operatively. So let's go into a question here. So we're going to say this patient has an opposing second molar, favorable force factors, so there's no parafunction, favorable bone density in 18 and 19, favorable available bone in 18 and 9, or I'm sorry, 18 and 20, favorable available bone in 18 and 20. However, the 19 site has poor bone quality and quantity. So again, if we look at the sites, number 18 and 20 have good density, good available bone, And as you can see from these measurements, 19 is definitely compromised. 18 and 20 are not. Force factors low. So with that being said, I went through those 5 factors down below in the blue. So for this treatment patient, my question is, would you select option 1, which would be 3 implants, 18, 19, and 20. Option 2, which would be 2 implants, 18 and 20. 3 would be 2 implants, 19 and 20. 4 would be 2 implants in the 19 and 20. You have the ponic in the 18 area. And then option 5 would be 2 implants in the 18, 19, and the ponic number 20 area. So go ahead and pick how many implants and in what position you would put those implants in this particular patient with no force factors, good bone density, available bone in 18 and 20, compromised bone quality, quantity in 19, and opposing a second molar. Robert, give us the answer. Okay, we have 89. Excellent. Very good. Very good. So option 2 is the correct answer, and that actually is this patient. That's what should be done in this patient for a couple reasons. Number 1, because we have very little force factors and we have a second molar, we need a second molar on the lower, but because the force factors are so low and we have good sites in 18 and 20, you put 2 implants in and you bypass the number 19 site. So that would be ideal. However, I'm going to throw a little curveball to you tonight. So I'm going to give you a different scenario. We're going to just fake this and say that we need to place a 19 implant. So we're going to say this patient had parafunction, was a bruxer, it was opposing implant crowns. So we need to put an implant in 19. But as you can see from that 3D image on the left, we place that implant in the bone, we have a big defect there. So let's talk about this defect. Number 1, trying to surgically place the implant into this thin bone is very difficult. What a lot of doctors do is they'll start drilling in the very coronal aspect of this, and then because the burr width is wider than the available bone, they'll end up drilling too deep. And guess what's too deep? You have the nerve there. So you have to be very, very careful. So what do we need to do? We need to build that bone volume up to where it once was. So we need to build that buccal aspect up. How do we do that? Well, if you look at this 3D image on the left, my question to you is, we need to build that bone volume up. And how are we going to do that to make it the most predictable? So our treatment plan is going to be, we need to put 3 implants in, but we want to make this the most predictable treatment for this patient. A, do we do implant placement, no bone graft, close it up, call it a day, and look at 2-dimensional images all for the rest of this patient's recall exams and not see that there's no facial plate there? Or should we do number B, implant placement and do a graft at the same time you place the implant? Or do we bone graft, close it up, let it heal, come back in, and delayed implant placement? So with that being said, A, B, or C as the most predictable treatment for this patient with this existing defect. Okay, let's see. Very good. Hey, Robert, we got a good group. Excellent. Yes, very good. Yes, we do. 84%. So let's talk about that. Why is it that B would not be a good answer? Well, if we look at that, if you look at the defect in A, you can see where the crown needs to be, where the implant in the center image needs to be placed. So I have measured here about 5.8 of that, the facial aspect of that implant is going to be exposed. So let's do some math here. So we want at least a 5 millimeter implant in a molar area. If we look at how much ideal bone should be on the facial to preserve that facial plate, to preserve the soft tissue drape, we want 2 millimeters of bone on the facial. On the lingual, usually we can get away with minimum of 1 millimeter. So if you do the math, 5 millimeter implant, 2 millimeters on the facial, 1 on the lingual, we need 8 millimeters of bone. If you go back to what I had measured, we had 2.1 millimeters. So we have to grow a lot of bone. Now, if you place this implant and you're going to grow 2 millimeters of bone on that facial aspect, that is very, very difficult. Because why? I'm just going to go back here and look at this 3D image. Look at those threads exposed. Once you have those threads exposed like that, that can form a biofilm on it, which is basically bacteria. And that interferes with growing new bone over top. So in some cases, yes, you can grow bone with a facial defect. However, with this one, I believe it's a little bit too significant. And your best bet is do what's best for the patient and the most predictable with the least amount of morbidity. And that would be bone grafting it, letting it heal, coming back, place the implant in the ideal position for the longevity of the prosthesis. So I know everyone wants to get everything done yesterday, but always put yourself in the patient's view. I mean, you don't want this patient coming back in a couple years with a problem. So do it the most predictable way. So with our last question of the night, if 3 implants are placed, like I just showed you in that example, would you splint the 3 crowns or would you make them independent? According to the latest literature. So according to the latest literature, would you split the crowns or make them independent? Okay, Robert. Now, I don't even think I explained this one to Robert, okay, because, oh, this is perfect, okay. There wasn't a right answer there. There was 51-49. The answer is there is no correct answer. If we look at the literature is, there's numerous studies. There's probably 10 good studies out there that have looked at either splinting or independent crowns. And you'll find half say to always splint, half always say to keep them independent. So my suggestion would be, a good rule of thumb is when you have force factors, we know one thing, bone does not take stress very well or overload of stress. So when you have a lot of stress, you want to splint the implants. If there is very little stress and you have good bone and you have good sized implants, then independent implant crowns are fine. But the majority of the time, you are going to have some force factors. So splinting in those cases with force factors are significantly better. Why? When you splint the crowns, they're exponentially stronger. So if you look at 3 independent crowns and you put force on those 3 crowns, that would be 3 times X. However, if you splint them, it's X to the 3rd power. So it's exponentially stronger, and that is always better. But if you look at the literature, like I said, And one factor that doesn't go into almost all these studies that are out there is parafunction. I would love to see a study that would look at patients who have significant parafunction, splinting versus non-splinting, because I think there would be a significant difference with that. So with that being said, I've spent, wow, almost an hour and a half of your time. Just being on this webinar tonight, you will start to get my newsletters, which are about once a month. I always write an article, and then I also have questions to quiz you on anatomy, pathology, and treatment planning. Heidi, our executive director, which most of you know, will be sending you via email verification. Is that correct, Heidi? Or Robert? I believe.
Correct.
Yeah, they will be sent. However, give her a day or two to get those out. We've been getting a lot of questions about the courses in the last webinars. So they asked me just to do a brief summary of what we do teach at the Mission Institute. Our next course is actually next month, September 25th, 26th in Orlando. This is the treatment of multiple edentulous sites and edentulous sites. So we go teach you about all-on-4, treating 4-arch prostheses. We also talk about guided surgery, zirconia prostheses, and we teach you about acellular dermis, which is becoming very popular in the field of implantology. Session 3, which is going to be in October, is all bone grafting. So this is a great course, one of our most popular. I teach you a very easy, simple way to graft. We teach everything from, we do soft tissue procedures. So you'll do all these graft procedures in a laboratory session. We teach you soft tissue grafting. We teach you how to draw blood, platelet-rich fibrin, sticky bone. We teach you how to use the piezos, etc. Also at S3 in October, I teach a one-day, I call it a CBCT boot camp. We strap you to your chair and we give you about 10 hours of CBCT, everything from anatomy to treatment planning, pathology, interactive treatment planning, how to do navigational surgery, how to print guides. It's an all-in-one, it's one full day, and that's also going to be in October in Orlando. Session 4 is dedicated to the posterior maxilla. We teach you all about the anatomy. So I just gave you a Cliff Note version of it tonight. We have some great models. You'll do about 10 different procedures, sinus lifts, crestal lifts, bumps, all different types of grafting into the maxillary sinus. S5 is our immediate load, immediate placement session. And also, this is our peri-implant disease session. So we teach you all about soft tissue problems, how to remedy those, and also how to place implants immediately, and also when and when not to load them. We also give you a comprehensive board review. If you are going to be taking any boards, we give you a comprehensive review of Implantology 101 that is very, very helpful for that. We also have a team training at that session. We have a great group that you bring your staff. We teach the front office about insurance, what to say on the phone, what not to say. And then we teach your staff all about setting up rooms, what you need to start an implant practice, things like that, internal marketing. It's a really good group course for your group. And one of our popular courses outside of our surgery program is an implant complications course. This is a very comprehensive course that goes over every aspect of implant dentistry, from surgery to prosthetics to maintenance to the legal aspects. And again, that is a boot camp in itself. And the last course is our Prosto Boot Camp. This is a 3-day course that is Thursday is single and multiple implant prosthetics. Friday is all edentulous arch prosthetics. And then Saturday is all removable overdenture, edentulous arch. You do a lot of lab. You do probably 2 or 3 sessions per day, lab sessions. And we go over a lot about occlusion and the step-by-step protocols. With that being said, do we have any questions, Robert?
Yes, we have a couple. So the first one is regarding the Reclast. How long after starting infusions is it an absolute contraindication? One had a conversation with a rheumatologist today about this, and he said that it's not significant risk until they've been on it for 3 to 5 years.
Yes, so that is exactly right. That usually the way that, if you look at the clinical studies on this, and I pulled these out, 10,000 patients, 3 of them got osteonecrosis. Okay. However, if you read my textbook, I have a case in there of a patient who had implants and a year later developed osteonecrosis around the implants, asymptomatic for 1 whole year. So the rheumatologist said it's fine, and that is a partial get out of jail card. My concern, and someone I have the utmost respect for, Dr. John Suzuki, who for many years has been the FDA director for dental products and now is in the immunology FDA part. He is the one who basically said, you know what, if the FDA puts on the label of the package not to do it, there's a good, you probably shouldn't do it, because if there is a chance that it does become osteonecrotic, that usually results in the resection of the jaw. So if I look at it from a medical legal standpoint, that means you have to go in front of a jury and explain why you did this. And if you say that the rheumatologist said you could do it, or, you know, Resnik said it in the 3rd edition of Contemporary Implant Dentistry, that doesn't go too well when the FDA put a warning on it. So can you do it? Yes, but you better be very, very careful and have a good consent form. And we have those. We have an actual bisphosphonate consent, and that patient needs to get that consent weeks prior to the procedure. They need to go over that. They need to sign off that they understand that there is a chance that that could happen. And that's the only way I would say it would be a relative contraindication. If you're early on your learning curve, life's too short. You don't need the hassle of dealing with it, and I would refer it.
Okay. There's a couple more, I guess, regarding Reclast. Does the FDA warning for Reclast supersede a well-done informed consent? And does the FDA warning also apply to extractions, not just implants?
That's a great question, because I asked Dr. Suzuki that, and they generalized that as any type of surgery in the mouth. So it does not exclude or disclude any of the extractions or periosurgery or anything like that. If you have a good consent, that helps your case. However, what I caution people on, and as you all know, I do a lot of dental malpractice. I almost 100% defense. And what I always tell doctors is, do you want to be put in a position where a plaintiff's attorney is going to pick up this piece of paper that's going to say you should never do it, and then they see this poor patient that had their jaw resected and has permanent nerve damage and whatever. So a consent form does help. I would say If you have a good consent form, a plaintiff's attorney is going to less likely take the case. So, but it does not say that you're off the hook. When something bad happens, they look at anything, someone to blame, unfortunately.
Okay, thank you. Can we use diode laser with saline if we don't have a biolace for peri-implantitis treatment, or will it cause necrosis?
You know what, there are so many lasers out there, and actually Dr. Suzuki is the expert on that. My suggestion is there are so many different types of lasers that you contact the specific manufacturer who makes the laser and the specific model. So I've had some, there's some manufacturers that have different models, that some are good and some can be detrimental. If you look in the textbook, I have one case from a electrosurge that is a very ugly case that happened from someone just using electrosurge. So the same with lasers. There are some that are good, and I hate to generalize it. I would look at the specific one and get in writing which your specific model, if that can or can't be used.
Thank you. What is your opinion on implant-assisted RPD? Is it a valid treatment, or our local periodontist said it's a transitional treatment modality? What do you think?
That's another good question. I actually started I added this into our lecture because it's something that we never used to do in the past. 30 years ago, we played around with it where patients with bilateral edentulosum in the mandible, we would put an implant back in the second or sometimes even third molar areas to kind of help retain a partial denture. But the problem is when you fixate a implant with a partial is made to rotate. So it rotates over the abutment tooth. So the contour of the abutment tooth. So if you prevent that, then it puts leverage on that tooth and can actually avulse an abutment tooth. So the studies that have been done recently, and I do have this in the most recent textbook, Contemporary Implant Dentistry, if you are going to place implants for a partial in the bilateral edentulous case, bilateral posterior edentulous, what you want to do is put the implant as close to the tooth as possible. So if you have, say, for instance, 22 through 27 remaining dentate, if you put them in the 21 and 28 position, that works out better than putting them in the molar areas because it allows a better force distribution and allows the implants to rotate. So that's what the studies show. We're doing them more often. And again, if you would have asked me that question 10 years ago, I would say you don't want to do it. But the studies are not bad. As for a transitional treatment, it possibly could be termed that, but they are seeing results in these studies. The problem is we don't have long enough studies to say if it's a long-term treatment.
Thank you. What are your feelings about the validity of a CTX test?
Okay, CTX, that's another good question. So we could talk all night about CTX. CTX is a blood test that was really made popular by Dr. Marks in Florida, who is one of the experts on osteonecrosis and bisphosphonates. And basically what a CTX does is it looks at the osteoclast turnover. And however, if you, unfortunately, for Dr. Marks, he's been a huge advocate of it. The ADA has really said that it's inconclusive. AMIS, the Oral Surgery Association, it says it's inconclusive. So to use it as the sole determining factor in whether you do the case or not, I would not do that. Using it as an adjunct, yes, you can use it because it is going to give you information. The problem is I don't think they have enough data to determine what an adequate score is and what an inadequate score is. But it's certainly something that won't hinder it. It's just I won't use it as the sole way of diagnosing or preventing osteonecrosis.
All right, thank you. We have a couple of questions in regards to the allergies. How do you determine titanium allergy? How do you diagnose it, or do you predict titanium allergy?
So the only way, here is what, I'll tell you what I get a lot of phone calls on, and I might have mentioned this. I just placed an implant. The patient's in a lot of pain. I think they're allergic to titanium. Or the implant failed after 6 months of being in the mouth. I think the patient had an allergy. That usually are not the symptoms. Usually you will see a localized redness or irritation around the area of surgery. You will definitely have pain. But the only way to determine that is to send the patient to their physician and or allergist or dermatologist and get that Melissa test. That is the test now, as I was saying before, that cardiologists or cardiothoracic surgeons and orthopedic surgeons are using to screen for that. Are we there yet for screening our patients for titanium allergy? I don't think so. There are so many more implant patients than orthopedic and the cardiovascular patients. So I would say that you know, I think it's a little premature yet to screen every patient. But the answer to the question is the way you determine it is not a patch test. What we thought in the past, it's with a blood test.
Great, thank you.
Okay, why don't we take one more, as I think we're getting pretty late here.
All right, then I'll try to pick one that Dr. Awad asked, when is the complication course taking place?
Okay, that's a good question. Heidi is online and she can answer that question. Why don't you give me another clinical question?
All right, sound good. Is this the Zometa patient, and if so, would the entire procedure be contraindicated?
Well, Zometa, if the patient is on truly Zometa, the only way that they would be on the regular doses of Zometa is if they're metastatic cancer or multiple myeloma. And I would say if that is the case, those patients are usually terminal and it would not be a good idea to do it. However, Reclast is also Zometa, but it is Zometa at a very low dose. So it's not as toxic. So if you look at Zometa compared to Fosamax, Zometa is about 10,000 times more toxic than what Fosamax is. So that's why it's such a concern. And also it's in the IV form versus the oral form. The reason why they're using Zometa as an osteoporotic treatment is a lot of patients can't take oral bisphosphonates because of side effects. So this is a one and done. It's an infusion once a year.
All right. Well, thank you very much, Dr. Resnik. It's always a pleasure to work with you and listen to you lecture on all these interesting cases that you come about. So thank you very much.
Thank you to 3DDX. Thank you to our panel. Heidi asked me to put this up because she always gets this question. If you're looking at the textbooks I was talking about, contemporary implant dentistry is the one that was just published in February by Elsevier. That's a whole new edition. The Avoiding Complications was published a couple years ago, and that is just on complications. Contemporary implant dentistry is basically the surgical manual that we use at the Mish Institute. So with that being said, thank you to everyone for tuning in. Look for future webinars. I appreciate, we had a great response tonight, and everyone stay safe, and we'll see you on the next webinar. Thank you.
Thank you, Resnik.